Good afternoon, sir. My Dr. Gowri Naidu, surgical oncology, SR. Today I'm going to present seminar on pancreatic incidenteloma. Pancreatic incidenteloma is defined as lesions in pancreas that are found incidentally during an imaging study for abdomen not intended to look for pancreatic pathological process. This phenomenon is not new to pancreas and often observed in other organs such as adrenal glands, thyroid, parathyroid, pituitary, liver, prostate, and kidneys. The first case of pancreatic incidenteloma was described by Caustic in 2001. Coming to incidence, pancreatic incidenteloma may be solid or cystic, and roughly they are equally distributed. That is, solid lesions are around 48% and cystic lesions are around 52%. And they are located in most commonly in distal pancreas about 56% and in head of the pancreas in 48% of cases, and nearly 12% of the patients had no pancreatic lesions, and incidence is rising due to advancements in imaging and their easy availability. And most common imaging study by which pancreatic incidenteloma was detected is CT scan, and commonest reason for imaging was patient during evaluating for genitourinary or renal symptoms in 61% of cases, and evaluation for asymptomatic abnormal liver function test in 13% of cases, and pancreatic incidenteloma were detected while during screening or surveillance for other cancers in 7% of cases, and evaluation of chest pain in 6% of cases. And there is recent published studies have shown that incidence of pancreatic incidentoma is rising, and in a large series of pancreatic surgery where 6 to 23% of operations were performed for pancreatic incidentalomas, and most of the pancreatic incidentaloma were in that study was solid lesions, that is 60%. And the reported incidence of incidental cystic pancreatic lesions varies depending upon the imaging technique, and the prevalence of those cystic pancreatic lesions on CT scan was 0.5 to 3%, and on MRI it is 18 to 19%, and in a post-mortem study cysts less than 1 centimeter were detected in 24% of cases. Coming to malignancy rate in pancreatic incidentoma, in a larger series of 1944 pancreatic duodenectomy cases, which were done over 8 years, found out that 6% of the surgeries were done for solely for pancreatic incidentalomas, and among those 31% were malignant and 47% were pre-malignant. And among overall in pancreatic incidentoloma in this series, three most common diagnoses were 30% of intraductal papillary mucinous neoplasm, 17% were mucinous cystic neoplasm, and 10% were pancreatic duct adenocarcinoma. And they found out that surgery improved survival when comparing with patients who presented with symptomatic disease. These findings favor a more aggressive approach towards pancreatic incident. Coming to solid pancreatic incidentomas, most of the solid pancreatic incidentalomas are malignant. Among solid pancreatic incidentaloma, incidence of benign lesions were 6 to 21%. And among those benign solid pancreatic incidentoma, 70% are due to chronic pancreatitis, of which 60% are due to alcohol-induced chronic pancreatitis, and 4 to 11% were due to autoimmune-induced chronic pancreatitis. Coming to the specific characteristics on imaging studies to differentiate benign from malignant lesions depend basically on three factors: tumor features, that is size, density, echogenicity, calcification, and duct dilatation. Second is quality of study and experience of the person interpreting the study. It has been described that changes compatible with malignancy occur as early as 18 months prior to the diagnosis. Under solid pancreatic incidentoma, pancreatic cancer, pancreatic endocarcinoma, pancreatic neuroendocrine tumor, pancreatic metastasis, and chronic pancreatitis, which were most commonly detected. Coming to pancreatic cancer, the most frequent solid lesion in pancreas is pancreatic carcinoma. At the time of diagnosis, in a symptomatic patients, 40% are locally advanced and 40 to 50% were metastatic, leaving less than 20% who are candidates for potentially curative resection. And the earliest imaging finding of pancreatic carcinoma before before a mass becomes apparent is pancreatic duct dilatation or pancreatic duct cutoff. Pancreatic cancer on imaging, contrast enhanced CT scan, it appears as a hypovascular, hypoenhancing lesion. On MRI, hypointense on unenhanced T1 weight sequence, and hypointense or isointense on T2 weight image. And FDG PET on FDG PET for diagnosis of pancreatic carcinoma in patients with Normal blood glucose level sensitivity is 85 to 100% and specificity was 67 to 99%. And combination of PET and CT may offer a better accuracy. This is the CT scan showing focal hypodense mass in body of pancreas with upstream dilatation of the main pancreatic duct, which is pancreatic adenocarcinoma. On endoscopic ultrasound, lesion in pancreatic cancer appears as a hypoechoic and non-homogeneous irregular mass, and factors associated with failure to detect pancreatic cancer on endoscopic ultrasound include chronic pancreatitis, diffuse infiltration of the tumor, and recent history of acute pancreatitis. In these conditions, it is very difficult to identify pancreatic cancer on endoscopic ultrasound. And another investigation is endoscopic ultrasound guided FNAC, which has sensitivity of 64 to 98% and specificity of 71 to 100% for the cytological diagnosis of pancreatic carcinoma. And coming to serum tumor markers, which are helpful in differentiating benign from malignant pancreatic mass. CA199 is the gold standard marker for pancreatic carcinoma with sensitivity and specificity as high as 87 and 98% respectively. Addition of other tumor markers like CA125 does not increase the diagnostic accuracy of CA199. Coming to islet cell tumor or pancreatic neuroendocrine tumor, which accounts for 2 to 4% of all pancreatic neoplasms, and they are divided into functioning and non-functioning. Functioning pancreatic neuroendocrine tumors accounts for 60% of all pancreatic neuroendocrine tumors, which present with clinical syndromes like insulinoma, gastrinoma, glucagonoma, VIPoma, or somatostatinoma. And non-functioning pancreatic neuroendocrine tumors accounts for 30 to 40% of all pancreatic neuroendocrine tumors. These are the pancreatic neuroendocrine tumors more likely to be discovered incidentally when symptoms due to presence of mass are not yet obvious. And multiple pancreatic neuroendocrine tumors generally associated with other endocrinopathies such as multiple endocrine neoplasm or von Hippel-Lindau syndrome. On CT scan, pancreatic neuroendocrine tumor appear as isodense or moderately hypodense mass with enhancement on contrast. And there are also calcification, necrosis, and cystic degeneration seems to be more common in large non-functioning tumors. On MRI, low signal intensity on T1 weight images and high signal intensity on T2 weight images. And sensitivity of MRI is 78 to 91%, which is equal to dynamic CT scan. And MRI is more sensitive than CT for liver and bone metastasis. This is the incidentally found pancreatic neuroendocrine tumor on CT scan. Well-defined hypervascular lesion in head of the uncinate process. And this is the MRI scanning showing incidentally detected pancreatic neuroendocrine tumor with hypervascular in the tail of the pancreas, peripheral arterial enhancement. Endoscopic ultrasound, pancreatic neuroendocrine tumor are identified small size less than 5 mm in size, and tumor located in tail of pancreas are less likely to be identified by endoscopic ultrasound. And scintigraphy using indium octreotide has sensitivity of 67 to 91%, and it is used for diagnosis and staging and also follow-up. And carbon 11 5 hydroxy tryptophan PET has recently shown good results in detecting small gastrinomas and non-functioning pancreatic neuroendocrine tumors. And coming to pancreatic metastasis to pancreas is uncommon. Incidence of patient having advanced tumor in autopsy studies is 3 to 11%. Most common primary to metastasis to pancreas are renal cell carcinoma, lung adenocarcinoma, breast carcinoma, and melanoma found during initial workup or follow-up. Time interval between primary and secondary can be up to 20 years, particularly with renal cell carcinoma. This is a CT scan showing patient who underwent left nephrectomy for renal cell carcinoma developed a metachronous metastasis to pancreatic tail. The characteristic enhancement of metastatic lesion on arterial phase imaging, as well as posterior displacement of pancreas, the absence of left kidney. The pancreas was displaced posteriorly. Pancreatic metastasis on CT scan can be seen as three patterns. They can appear as a single mass, they may present as a diffuse pancreatic gland enlargement, or they may present as multiple pancreatic mass. And among these three presentations, single mass presentation is most common, 50 to 73%. It appears as a ovoid, well-defined marge, iso or hypodense on non-contrast phase, and vascular invasion is rare. If found, it is invading splenic vein. It shows splenic vein obstruction, and portal hypertension are also reported. On MRI, pancreatic metastasis appear as hypointense on T1 and hyperintense on T2. On endoscopic ultrasound, pancreatic metastasis appear as a hypo or isoechoic round well-defined lesion. Metastasis to other organs can be as frequent as 95%, and this finding supports the metastatic nature of the disease. Coming to another presentation, so chronic pancreatitis. Morphological changes due to chronic inflammation of the pancreas, which includes pancreatic atrophy or calcifications, focal enlargement, and pancreatic mass may also occur. And there are also fibrosis, may be uniform or diffuse fibrosis. If fibrosis is non-uniform, it may resemble a pancreatic mass on imaging studies, where it is very difficult to differentiate pancreatic carcinoma from chronic pancreatitis. And nearly 10% of cases which are presumed to be pancreatic cancers that are surgically operated have been composed of pseudotumor forms of pancreatitis. Among them, nearly half of them are focal forms of autoimmune pancreatitis involving mainly head. So 10% of patients who are operated thinking that presumed that pancreatic cancer were finally found to be pancreatitis due to autoimmune pancreatitis. And on endoscopic ultrasound, chronic pancreatitis appear as there is a criteria which include at least 3 of the following findings: heterogeneous, echogenicity, presence of lobularity and lobular gland hypering, presence of echoic foci of duct irregular dilatation, branch dilatation, pancreatic, presence of cyst of 3 of these findings present, then we can label it as a chronic pancreatitis. Coming to autoimmune pancreatitis accounts for 4 to 11% of chronic pancreatitis. Up to 33% of autoimmune pancreatitis may present as a discrete mass mimicking pancreatic tumors. And high serum levels of, to differentiate autoimmune pancreatitis from pancreatic tumors, serum levels, we have to do blood investigation. Like in blood investigations, there is a raised serum gamma globulin, IgG, Ig4, or auto antibodies like anti-nuclear autoantibodies, anti-lactoferrin antibodies, anti-carbonic anhydrase antibodies, and rheumatoid factors raised in rheumatoid factor can also help for diagnosis. On biopsy, autoimmune pancreatitis shows marked interlobular fibrosis and prominent infiltration of lymphocytes and plasma cells in periductal area are seen. Coming to cystic pancreatic incidentelomas, most cystic lesions of pancreas are benign. It is important, however, to characterize such lesions and to distinguish true cystic lesions from pancreatic pseudocyst. Most cystic pancreatic lesions are incidentally found on imaging studies performed for other pathologies, and as many as 35% of patients are totally asymptomatic at the time of discovery. And serous cystic neoplasms, mucinous cystic neoplasms, intraductal papillary mucinous neoplasms account for majority of cases, more than 90% of primary cystic pancreatic tumors. Radiographic classification of pancreatic cystic neoplasm based on imaging features. There are 4 different types of cystic lesions: unilocular cyst, mostly pseudocyst, and serous cystadenomas present as unilocular cyst, and microcystic lesions, serous cystic neoplasms present as a microcystic lesion. And macrocystic lesions examples are mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, and a solid cystic lesion, intraductal papillary mucinous neoplasm. Coming to unilocular cyst, pancreatic pseudocysts are the most commonly encountered unilocular cyst, and others includes are mucinous and serous cystadenoma, lymphoepithelial cyst, retention cyst, developmental cyst, epidermoid cyst in intrapancreatic spleen, endometrial cyst, and cystic neuroendocrine tumor or infectious cyst. And unilocular cyst in patient with past history of pancreatitis, almost always it is a pseudocyst. And a lobulated unilocular cyst located in head of pancreas should raise suspicious of serous cystadenoma. Coming to microcystic lesions, serous cystic neoplasms usually demonstrate polycystic or microcystic pattern consisting of cyst collection of size up to 2 centimeters in size. They are usually lobulated, and the septa and wall are enhanced on imaging studies. And there is a classical characteristic feature is stellate pattern of calcification, which is seen in 30% of cases. in serous cystic neoplasm, and pancreatic duct dilatation is rarely seen, and honeycomb or sponge pattern is found on CT imaging as a result of microcystic nature of this tumor, which is seen in 20% of cases. And the benign nature of this lesion allows follow-up in asymptomatic patient. And this is the incidentally found serous cysternoma on CT scan, showing polycystic lesion in head of pancreas with thin internal septations, which is a case of incidentally found serous cysternoma. Macrocystic lesion. Mucinous cystic neoplasms and branched duct intraductal papillary mucinous neoplasms usually present as macrocystic lesions. Mucinous cystic neoplasm mainly involve body and tail of pancreas and does not communicate with main pancreatic duct, whereas branched duct intraductal mucinous neoplasms also have connections with main pancreatic duct. And it is important to differentiate serous from mucinous cystic neoplasms because surgery is the treatment of choice for mucinous cystic neoplasms, whereas serous cystic neoplasms we can observe. And mucinous cystic neoplasms, there is a classical peripheral axial calcification which is highly suggestive of potential malignant nature in mucinous cystic neoplasm. And other differential diagnosis of macrocystic lesions in pancreas are lymphangiomas, lymphoepithelial cyst, infectious cyst, mesothelial cyst, and duplicate cyst. This is the this is the maximum MRCP showing cystic mass with lobulated borders located in uncinate process of pancreas, which is a branched duct intraductal papillary mucinous neoplasm. Solid cystic lesions, tumors with this morphology are solid pseudopapillary neoplasm, pancreatic blastoma, cystic metastasis, cystic degeneration in solid tumors, or malignant transformation in cystic tumors, and hemorrhagic pseudocyst. And MRCP is superior to CT scan to characterize these tumors. Most tumors in this category are malignant and should be surgically treated. Solid pancreatic incidentalomas are considered malignant until proven otherwise. And most guidelines reach the consensus that if it is potentially resectable, solid pancreatic mass on imaging is in an otherwise healthy patient with no clinical or biochemical characteristics suggesting a benign condition should prompt surgical treatment. And indication for surgery in pancreatic neuroendocrine tumors are any functioning pancreatic neuroendocrine tumor or non-functioning pancreatic neuroendocrine tumor with size more than 2 cm. And if pancreatic neuroendocrine tumor of size less than, those patients should be monitored. And pancreatic neuroendocrine tumors of size between 1 to 2 cm should be considered for enucleation if it is superficially located. This is the algorithm showing management of pancreatic incidentoloma. If it is a solid pancreatic incidentoloma, 80% of them are malignant, so solid tumors, surgical resection has to be done. In case of pancreatic neuroendocrine tumor, if its size is more than 3 cm, we have to do surgery. If it is less than 2 cm, enucleation if they are superficially located. And if it is less than 1 cm, monitoring. Coming to cystic pancreatic incidentoloma, cysts require surgery are mucinous cystic neoplasms, solid pseudopapillary neoplasms, and main duct intraductal papillary mucinous neoplasm and mixed intraductal papillary mucinous neoplasm. And dissection criteria for cysts, simple cysts are cysts more than 4 cm in size, symptomatic cyst, enhancing mural nodules more than 5 mm, main duct diameter more than 6 mm, cyst increase in size more than 2 mm per year or elevated CA19-9. And resection criteria for branched duct intraductal mucinous neoplasm or patient having obstructive jaundice, patient having enhanced solid nodule or main pancreatic duct more than 10 mm or cyst size more than 4 cm. And surveillance in branched duct intraductal mucinous neoplasm is advised. Surveillance is advised in branched duct intraductal papillary mucinous neoplasm and in indeterminate cyst less than 2 cm, 3 cm. And this is an algorithm showing management of solid pancreatic incidentoloma. If patient is a good surgical candidate, CT scan has to be done and endoscopic ultrasound has to be done. And if there is a suspicious of pancreatic cancer, we have to go for surgery. And suspicious of islet cell tumor, pancreatic neuroendocrine tumor, confirmation has to be done with scintigraphy, and surgery has to be done. And unless if it is not multiple neuroendocrine tumor, if it is suspicious of chronic pancreatitis, we have to go for endoscopic ultrasound guided FNAC, and confirmation by serum gamma globulin IgG and IgG4 autoantibodies, and surgery is done if malignancy cannot be ruled out or if it is symptomatic. And if there is a suspicious of metastasis, endoscopic ultrasound guided FNAC has to be done, and we have to observe and repeat repeated by CT scan in 3 to 6 month interval. And if patient is not surgically fit, then do CT scan and endoscopic ultrasound FNAC, and malignancy is proved, patient has to be treated palliative. And if it is benign, we have to observe with CT scan with 3 to 6 months interval. Coming to management of cystic pancreatic incidentelomas, as I said, they are classified into unilocular, microcystic, macrocystic, and mixed. Unilocular, if it is cyst size is more than 3 centimeters, we have to go for surgery. If cyst size is less than 3 centimeter, if it is benign, showing benign pattern, we have to observe. During observation, if the size is increasing and more than 3 centimeter, we have to go for surgery. And if it is a suspicious of if it is having suspicious pattern on imaging, we have to go for endoscopic ultrasound and FNAC. And if it is found to be mucinous, and we have to go for surgery. If it is found to be non-mucinous, we have to observe. Coming to microcystic, microcystic are usually polycystic and microcystic, involving more than 6 compartments, and with benign pattern, we have to observe. And if it is having suspicious pattern, we have to go for endoscopic ultrasound or FNAC. And if we found it as a mucinous, we have to go for surgery. If it is found to be non-mucinous, we have to observe. Coming to macrocystic, we have to go for MRI or endoscopic ultrasound or aspiration of the fluid. And if we found it as a mucinous, we have to go for surgery. And if it is non-mucinous, we have to observe. And mixed cystic lesion, we have to go for surgery. And some practical tips in pancreatic incidentoloma. CT scan with pancreatic protocol is the imaging of choice for solid lesions, and MRI is the modality of choice for cystic lesions, and endoscopic ultrasound and fluid aspirate analysis are used for indeterminate lesions. And solid pancreatic incidentolomas are considered malignant until proven otherwise. And high amylase and high carcinoembryonic antigen levels in the fluid suggest pseudocyst and mucinous neoplasm respectively. The simple cysts up to 3 centimeters with no worrisome features can be safely monitored, and surgery is considered for mucinous cystic neoplasm, solid pseudoepithelial neoplasm, main duct intraductal papillary mucinous neoplasm, and mixed intraductal papillary mucinous neoplasm. And surgery is considered for cysts more than 3 centimeters and serous cystic neoplasm more than 4 centimeters. And solid lesions up to 2 centimeters are likely to be malignant and will require surgical intervention. And solid pancreatic neuroendocrine tumor less than 1 centimeter are simply monitored, and large pancreatic neuroendocrine tumor more than 2 centimeters are treated by enucleation or resection.
I have a question. What is the suspicious pattern that you are saying that we need to observe to confirm between a benign and a malignant in the endoscopic ultrasound that they are seeing? And what are the surgical options for more than 3 centimeter unilocular pseudocyst that he was saying? He was saying to go for surgery. What are the surgical options that we can go for?
Okay, sir. Coming to first question, there suspicious findings includes, actually there are 2 findings: high risk stigmata and worrisome features. According to Fukuoka guidelines of international pancreatic, there are high risk findings and worrisome features. High risk findings includes patient having obstructive jaundice, and patient having enhancing neural nodules more than 5 mm, and main pancreatic duct more than 10 mm. If these 3 points are there, any one of these 3 points are there, these are considered to be a high risk stigmata and we have to go for surgery. And if they are having worrisome features includes patient having any pancreatitis, or having on imaging having cyst size more than 3 centimeters, or having enhancing mural nodules less than 5 mm, or having enhanced cyst wall, thickened cyst wall, main duct size between 5 to 9 mm, or there is any abrupt change in caliber of pancreatic duct with distal pancreatic atrophy, or on imaging there is any lymphadenopathy, increased serum levels CA 99, or there is a gradual increase in cyst size with having growth rate more than 5 mm per 2 years. If these are considered as a worrisome features, if these worrisome features are there, we have to do further imaging like endoscopic ultrasound. Coming to second question, if cyst more than 3 centimeters, if it is present in tail of the pancreas, we can go for distal pancreatectomy. If it is present in head of pancreas, we can go for Whipple's pancreaticoduodenectomy. And if it is present in body, we can go for central pancreatectomy or total pancreatectomy.
Dr. Gowri, I was talking about pseudocyst. In case of pseudocyst or unilocular cyst, are you going to go for Whipple's or pseudocyst?
No, pseudocyst, just cystogastrostomy.